Welcome to the McTox Curriculum, brought to you in collaboration with Western University, the University of British Columbia, and McMaster University. This presentation is part of the McTox Curriculum, which has been created for residents and fellows from PGY 1 to 5. Hi everyone! Thank you for watching the intermediate level of toxicology curriculum. This theme is about decontamination. By the end of this 10 minutes, you should be able to have an approach to decontamination, list the different types of decontamination methods, and identify the indications and contraindications of common decontaminations. Let's get started with a couple of cases. You will need to compare and contrast between them with regard to the toxins involved in their time of ingestion and possible decontamination options based on the data provided. The first case is a 39-year-old female who presents after taking a double dose of her regular lithium tablet about 4 hours ago. She has a past medical history of bipolar disorder and is taking 450 milligrams of lithium a day. What type of decontamination method would you recommend in this case? On to the second case, you have a 69-year-old gentleman who presents to the ED with decreased level of consciousness. It is reported that he took 20 tablets of his 100 milligrams per tab flecainide about 40 minutes ago. He has a past medical history of MI and ventricular tachycardia. He is also taking ASA and metoprolol. Again, what decontamination method would you recommend for him? By comparing and contrasting the two cases, you may notice that there are differences in the history provided. These differences have to be taken into account before reaching the final decision, which was not the same. The analysis that should take place becomes your approach to choosing the appropriate decontamination type. To make it structural, standardized, and easier to follow, the approach was arranged into 4 questions. Question 1. Is this a dangerous ingestion? 2. Can the substance be removed? Question 3. What are the options? And 4. Is removal more dangerous than not? Following these questions, one could select the most appropriate decontamination method if ever needed in any case. Now let's apply the approach to the cases and come up with the decontamination method of choice in each one. In case 1, after asking the first question, is the ingestion dangerous, and knowing that lithium regular dose is between 900 to 2400 milligrams per day in 3 doses, the physician can tell that this particular patient does not need a decontamination, as the ingestion was not dangerous because it lies within the recommended daily dose allowed. In the second case, the patient ingested a total of 2,000 milligrams of flecainide. Knowing that the regular dose of flecainide is 100 milligrams BID to a max of 400 milligrams per day, the physician can tell that this is a dangerous ingestion. Also, flecainide is a drug that can be removed, which is our answer to question number 2. Question 3 asks, what are the options? Single-dose activated charcoal seems to be the appropriate answer. But is removing the drug more dangerous than not? Well, flecainide overdose can lead to dysrhythmia and possible seizures. However, the patient presented very early, and if he is alert and awake, we can offer him activated charcoal to drink. But if he presented late and was drowsy, then the risk of aspiration is too high. There are 4 major types of decontamination based on the system of the body that's exposed to the xenobiotic. I'm going to start from out, in, and from up, down. The first system involves the outmost surface of the body. This is the dermatological method. From top down, we notice that there could be an ophthalmological exposure that may necessitate eye decontamination. Going a bit lower, you can see that the respiratory system can be decontaminated as well. Finally, to the bottom and most common system of decontamination, the gastrointestinal tract. Starting from the stomach all the way to the small and large bowels can be a site of decontamination. Now let's talk about each system briefly. Removing any contaminated clothes is the first step in any dermatological decontamination. Washing the patient's body with soap and water can be done once the physician has taken all of the precautions to protect him or herself and their entire healthcare team by gearing up with the appropriate PPE. A simple and effective way to decontaminate an eye exposure is to flush it immediately, preferably using the eye wash stations. Most of the time, any respiratory decontamination should have been started by the first responders. This is done by removing the victims from the scene and providing them with supplemental oxygen. This measure is usually sufficient in most of the cases. Finally, the most commonly used decontamination option is the GI tract. There are only a few GI decontamination methods: single-dose activated charcoal, whole bowel irrigation, gastric lavage, surgical or endoscopic removal, syrup of ipecac, and cathartics. It should be noticed that the use of syrup of ipecac and cathartics has been going out of favor. Nowadays, it is not recommended. We will talk about activated charcoal and whole bowel irrigation only in the next few slides. Single-dose activated charcoal is the most common GI decontamination method used these days. It's indicated in ingestions of a toxic dose of an adsorbable xenobiotic within the last 2 hours. Physicians should be aware about the situation where activated charcoal is contraindicated, mainly in cases of aspiration risk like vomiting, seizure, decreased LOC, and uncooperative patients. The recommended single dose is 1 gram per kilogram. It's a black slurry that can be mixed with any juice to make it drinkable, especially with children. Now let's talk about whole bowel irrigation. It's indicated in the case of an ingestion of a toxic dose of a xenobiotic that does not get adsorbed by activated charcoal, or at an overdose of a sustained release drug or in drug packers. To do it, the physician needs to secure the airway, which means most of the time the patient is going to be intubated. A proper sized OG tube or a specific whole bowel irrigation tube should be used. Whole bowel irrigation is contraindicated in the case of active GI bleeding, perforation, vomiting, intestinal obstruction, or if there is a risk of aspiration. The physician should listen to the patient's bowel sounds to check for ileus. Using polyethylene glycol, it should be started slow, at a rate of 0.5 liters per hour, titrating it up to 2 liters per hour as tolerated. The American Academy of Clinical Toxicology statement in 2004 about whole bowel irrigation says, "Whole bowel irrigation is not recommended as a routine GI decontamination in the poisoned patient." Before we conclude, please make note about these 3 questions. They need to be answered before the take-up session with your facilitator. Question 1. What are the levels of personal protective equipment? 2. Is there another way to calculate the dose of activated charcoal? And 3. What are the toxins that do not adsorb to activated charcoal? And that's it.